talk about the learnings from our Berkeley outpatient pilot program and what are the implications for scaling this program to the Cancer Center and other areas of UCSF. I want to showcase some of the many ways that UCSF addresses SDOH needs and some of the gaps. And importantly, as we're going through this, I really would like to engage you. And as you hear what I'm saying, I'd like you to think about insights about what more we can do to address these gaps. Okay, so let's just start with just talking about who are the patients that we see at UCSF. So when we look at our patients in 2024 at the Cancer Center, we had 36 had commercial insurance, 32 had Medicare, and 30% of our patients were Medi-Cal patients. So to qualify for Medi-Cal, generally you need to have an income that's less than 138% of poverty. So for a family of one, that means earning less than $20,783 annually. For a family of four, it means earning less than $43,000 annually. And I do want to qualify this by saying that some patients are able to earn more and still qualify for Medi-Cal through programs such as California Working Disabled Program and others. But the point that I'm trying to make here is that many of our patients face serious economic hardship, and medical costs are a real issue for them. And this is also true nationally. The toll of healthcare costs is a significant burden. We can see this in a study that was done by the Barrel Institute, which sent out over 1,000 surveys to patients throughout the country. This was a representative sample, and they asked them, which healthcare issue is most important to you? Shockingly, the top 5 issues of concern didn't have to do with the issues that we are always worried about. Quality of care, how providers treat you, communication. The top 5 issues all had to do with healthcare costs. And in order, it was affordability of health insurance, out-of-pocket costs, cost of health premiums, cost of prescription drugs, and cost of hospital care. So I think this is a really sobering statistic. This also impacts adherence to taking medication. So in a survey that was done by the American Cancer Society of over 1,200 patients and over 1,300 interviews, they found that 1 in 3 cancer patients struggle with medication costs. And among those earning less than $35,000 a year, 1 in 5 have skipped or delayed taking prescription medication. And when you look at this by race, the numbers are even more staggering. Patients who delayed or skipped taking medications among Asian Pacific Islanders was 40%, among Blacks 44%, and among Hispanics a whopping 58%. Looking here in our own backyard of the Bay Area, child food insecurity rate in San Francisco was 8.7%, and in Alameda, 12.2%. So that means about 1 in 10 children in the Bay Area suffer from food insecurity. And when you look at this again by race, the figures are even more stark. In Alameda, Black and Latino households are facing the brunt of food insecurity at 40% and 30% respectively. So what does this have to do with UCSF? I mean, really, these are issues that are caused by broader social drivers of health issues having to do with income inequality, national policy, our healthcare system. But we know that these factors, related to lower socioeconomic status, are associated with higher mortality, later stage at diagnosis, and poorer health outcomes. So these are issues that hospitals need to address. And we can see this association between income and health outcomes generally throughout the UCSF in terms of life expectancy. The higher the income, the longer the life expectancy. And if you look at the more extreme distribution of income, the top 1% and lowest 1%, there is a 15-year difference in life expectancy for men and a 10-year difference in life expectancy for women. And this, I'd like to point out, is based on a very large study of 1.4 billion de-identified tax records and Social Security Administration death records. And this is confirmed by many different cancer studies showing that patients with low socioeconomic status have higher mortality in pediatric cancers, colorectal cancer, stem cell transplantation, and many other cancers. So it is really incumbent on hospitals to look at these disparities and address them. And I do have some references on the last slide if you're interested in looking at those figures later. For some reason, I'm having trouble forwarding. There we go. So let me zoom in small for a moment and talk to you about the Berkeley outpatient pilot that we did, which was funded by American Cancer Society. And the goal of this was to find a workflow to connect patients with social drivers of health resources. The screening tool we used is a screening tool that's used throughout UCSF. It's a SDOH survey that is sent electronically through MyChart to all new cancer patients and then annually thereafter. And it asks about transportation, housing, financial and food insecurity, and other issues that could be a barrier to care. And these are captured in the SDOH screening wheel, which is in the patient's medical record, so that providers can see it, staff can see it, and these needs can be addressed. The results that we had in the Berkeley Outpatient Center were that our screening rate was very high. 99% of new patients were screened. There were some patients who didn't have MyChart, so they were contacted by our resource specialist to identify their needs. However, the survey completion rate was 60%, and of those who did complete the survey, 17% had moderate to high social drivers of health needs. So they found it difficult to pay for rent, or they were concerned about having enough food during the week or to the end of the month. One of the big concerns that we had once we saw how many data points were missing was that some of the 40% who did not complete the survey were probably our highest need, least resource patients. Those patients who are less tech savvy, who might not speak English, who don't have MyChart account, or who are just overwhelmed. So our measuring tool, the SDOH survey, was missing the data from these patients. And another concern was that many patients develop needs a few months into treatment once they need to stop working or their medical bills pile up. And we were asking this before patients start treatment. So because of this, the absence of this data, we decided to pivot. And whereas at the beginning of the pilot, we were only reaching out to patients who had documented SDOH needs, we decided to reach out to all new patients, regardless of whether they completed the survey, so that all patients would have information about how to access resources. So the intervention was to send a letter, and this was a manual process, to all patients screened. It was extremely time-consuming, and our resource specialist was able to send it out to 88% of the patients. We also developed postcards for distribution in the Berkeley Outpatient Center, and I'll show you a picture of those postcards, and now these are distributed throughout the Cancer Center. The contents of the letter focused on how patients can find resources, and we highlighted UCSF Find Help. This is a very large platform with many thousands of community and national organizations that provide free or low-cost care and support to patients. It's integrated into Epic, our medical record system, so that providers and staff can send resources through the medical record to patients and ideally track those referrals. And it also had instructions. Find Help can also be used independently by patients. And so we provided the website for that and instructions on how to use it. We also had the phone number of the resource specialist, or patients could simply reply to the message they got from her, information about how to reach a social worker with a social work phone number, how to contact the Cancer Support Center, and we also highlighted the support services site, which I'll go over, which has a lot of resources for patients as well. And if anybody's interested, here's the QR code that you can scan to access the UCSF Find Help site. So this is a picture of the postcards for distribution. It has information on Find Help and information on how patients can access support. So what were the big insights and takeaways from this project? So one of our concerns was that by sending out this letter, our resource specialist would be inundated and wouldn't be able to manage all the requests for help. However, we found that providing patients with information about how to access help or reach a social worker did not overwhelm the system. In fact, our resource specialist only had 24 patients reach out to her. That's 3%. And although there may have been a slight uptick in calls to the Cancer Support Center or social work, they were negligible. So the good news is that looking ahead and the implications, this means that we definitely can automate an SDO message to go out to all patients at the Cancer Center who have been screened for SDOH needs with information about Find Help, how to contact a social worker, how to reach the Cancer Support Center, and other key SDOH resources, maybe 4 or 5 organizations that can help with transportation, lodging, food insecurity, paying utility bills. The other takeaway was that not all patients respond well to electronic communication. That is a very low response rate, 3%. And so the implications for that is that I think it's really incumbent upon us to develop hard copy resource sheets for our less tech-savvy patients that has this type of information that can be distributed to all new patients as part of a new patient folder, something that they can hold on to and refer back to in the future. The other takeaway is that delayed needs are real. Some of the patients who received the SDOH letter from a resource specialist contacted her months later to ask for help getting support. So I think it's really important to find a way to integrate the clinic staff in the identification of SDOH needs as patients go through treatment. So, and to also have them involved in referral using Find Help, which is part of the medical record. So one of our thoughts is to implement a workflow where providers and other staff can ask, is there anything that will make it difficult for you to follow your healthcare plan? Are there any barriers to care that you're experiencing. And then to also have, as part of Find Help, uh, folders that are specific to clinics. So for example, Leukemia Lymphoma Society can have a folder with transportation needs that covers all the services offered by Leukemia Lymphoma, whereas the Breast Cancer Center can have organizations such as Pink Ribbon Good that provides transportation services that providers can easily refer to and make referrals. So now, just to broaden the lens and to showcase some of the work that UCSF does across the system, many of you are probably not aware that UCSF provides over $1 billion annually in free care to our patients. The Cancer Center alone provided over 3,000 hotel stays for our neediest patients in 2024 to help them stick to their care plan so that they could be in the hospital at 6 a.m. for surgeries. And I just do want to add that that budget has been cut in half, so we are scrambling to find alternatives. The Cancer Center also provided over 1,700 rides, Uber, Lyft, and Yellow Cab in fiscal year 2025. And again, this is really important in preventing no-shows and reducing delays in care. This really was made evident to me by Marissa Ortega, one of our PAs. She was talking about one of the patients who was coming in from a long distance and paying for Uber rides. And she suspected that this patient had delayed treatment because she couldn't afford this. And it turned out that this patient had managed Medi-Cal insurance. And managed Medi-Cal is required by law in California to pay for transportation to and from the medical center if transportation is a barrier for patients. So we informed staff throughout the Cancer Center about managed Medi-Cal transportation benefits. And also this was added to the after visit summary of patients with managed Medi-Cal insurance so that more patients would know about that. We also provided trainings to social workers and our community advisory board partners about the Medi-Cal HIP program. This is a really interesting program if you don't know about it. It allows patients who have private health insurance and need to transition to Medi-Cal to keep their private health insurance. Medi-Cal, if it deems that their care is going to be costly, which it will be with cancer, will just take on the private health insurance premiums and pay for them monthly so that the patient can stay on their private health insurance while on Medi-Cal, and then Medi-Cal will pick up the copays and deductibles. So we wanted to make more people at UCSF and in our community aware of this program because it really is a win for hospitals and a win for patients. I also want to highlight the food pharmacy program. This is an amazing program that provides 3 pop-up food markets 3 times a month for patients facing food insecurity in the East Bay. And here's the flyer with more information if you're interested. It has the dates and times and locations of where this food is provided. Just to give you a little picture of what this program does, in the last 4 years, over 460,000 pounds of food was distributed. And in 2024 alone, over 3,300 households were served, and over 1,036,000 pounds of food was distributed. And here you can see who are the community partners. You can see that 45% of the food is fresh fruits and vegetables, 55% are food staples, and this is managed by a wonderful individual by the name of Rigo Del Toro. So, what do we offer to patients and how do patients find out about our program? So, one foundational place where we offer information is the patient support website. Here we have the patient guidebook that covers how to make the most of your visit, what to expect, our programs, and we have just updated it. And we have printed new copies that are going to be distributed throughout the Cancer Center and to new patients. There is a newsletter with upcoming events, new patient orientation that patients can listen to in different languages. And I want for a moment to bring your attention to the financial section here. And I'm going to zoom into that. That information includes information about the Patient Financial Services Office, which offers families with an income at or below 400% of federal poverty level 100% assistance, so covers copays and deductibles. They will need to fill out a financial application, which is on that website. Also on that section, there is a CDOC California Dialogue on Cancer webinar that was done in collaboration with several cancer organizations in the Bay Area, including Triage Cancer. And it is a fabulous 1 hour long webinar that covers employment and disability, managing medical bills, how to appeal denials, and financial assistance programs. So that's really a wonderful webinar to view if you want to know more or if you're a patient and want resources. The website also offers a lot of information in other languages. You could see here a small section of it, some of the orientation videos. And of course, in order for patients to know about programs, our staff also need to know about programs. So we do have an intranet site for staff with all the different patient handouts, including patient information in other languages. Another program, and I'm coming to a close soon, is our Cancer Navigation Committee. This was the brainchild of Emeka Elkin, one of our nursing leaders, to figure out a way to address the patient experience across department and healthcare systems. We know how complicated healthcare is. And I feel that sometimes understanding the patient experience from all the different perspectives is hard. I like to liken the patient experience to the parable of the 6 blind people who encounter an elephant for the first time. And each person thinks it's something different depending on where they sit. So the person touching the tail says it's a rope. The person touching the tusk says it's a spear. The person at the ear says it's a fan. And hopefully, by bringing people together from different parts of the Cancer Center, we can really get a better picture of the full patient experience, and it will provide rich opportunities for filling in gaps and making improvements. So healthcare, as you know, is very complex, and it's not just about the interaction between a patient and the provider, but it is about many complex moving pieces coming together seamlessly. Just to provide an example that isn't atypical. So a patient who needs emergency spine surgery for spine cancer called chordoma, and this has to happen quickly. She's assigned to an oncologist before the surgery. The surgery goes well, but there's a complication post-surgery, and she's transferred to another hospital for rehab. She could be there for a month or 2. So in this case, I want you to think about who is in charge of the next steps of her follow-up care. Is it the radiologist, the oncologist, the surgeon? So I'm hoping that this navigation committee can surface some of these issues. and about handoffs to reduce these errors of omission, these unanswered calls, these areas where staff might not know about resources. And so we can fill in those gaps and cracks. Here is the mission of the Navigation Committee. Use a patient-centered approach to bring together diverse stakeholders across UCSF to improve care coordination, healthcare outcomes, and the patient and staff experience. Our objectives are to understand and improve workflows of adjacent departments, departments that work together, different navigators, to break silos and coordinate care more effectively, to address barriers that patients are facing, to ensure smoother transitions, and recognizing our budget challenges, to leverage technology and to be innovative to create more efficient and equitable care. So before I open it up to discussion, I want to close with a hopeful message. SDOH needs are not fixed. They're not immutable. Although many of the health-related social needs stem from national policies, tax policies that are outside of our control, where you live, geographic region, other inequities, state and local policies matter. We can see this in the differences in cancer mortality for states that adopted Obamacare and those who didn't. That affected barriers to care when patients were diagnosed. We know in very red states who did not adopt Obamacare, cancer mortality is over 2 times higher than in very blue states. And this may be partly healthcare policy as well as other issues to do with poverty or urban versus rural location. We also see this in policies regarding vaccination rates. States that had high adoption of COVID vaccination had lower mortality associated with COVID. So this means that the hospital policies that we adopt to improve access and level the playing field really can make a difference to our patients. So I think the challenge for us is to see the possibility, to think out of the box, to innovate. It's going to be hard to add staff, but I think we could maybe, for example, think about, is there a good return on investment? And to try new things as we did with COVID and to move quickly. So I hope you have a better picture of some of the programs that we offer for patients. And my hope is that we can really use the rest of this meeting to learn from each other. I would really like to learn from you what your ideas are about how we can improve access and address health-related social needs. So with that, I'm going to stop the share and welcome your questions and feedback and input.
Wonderful. Thank you, Keren. Lots of great detailed information and resources available. And we have a lot happening in the chat of one, drawing attention to specific resources folks want to follow up with, but also several questions that have come up as well. So I'm going to go back to the beginning of where I started noticing questions, because there's a lot of questions around the navigation committee right now. But going back, someone asked, what strategies are being implemented to reduce disparities in cancer screening, diagnosis, and treatment outcomes across different socioeconomic groups? That's a big question, but I'll turn it over to you to see what you'd like to contribute to that.
Well, I think that there are a number of different screenings. I highlighted the SDOH survey because that's kind of UCSF's new initiative. We do have a distress screening that measures emotional distress, and does ask about some SDOH questions, and we have a system to triage patient needs to psycho-oncology, social work, or interns who participate in the Patient Support Corps, which is a program that helps patients answer questions, record their visit, take notes during visits, and also address some of these lower level social drivers of health needs. I know that in the research field, and Ninika, I think that maybe you can speak to this more. There are some research initiatives to really address and provide more support to certain income groups. Do you want to add anything about what's happening in the research world, Dr. Palmer?
Sure. I'll just add broadly that, yes, there's certainly lots of things that are going on and research studies going on, including myself as I focus on prostate cancer and underserved populations, particularly in our safety net settings. And I know there are several other investigators across the Cancer Center that are also exploring low more vulnerable populations, low socioeconomic status, and racial ethnic differences as well. So I'm certainly not the only one. There's numerous going on, but that'll be something that we can explore further of how we share a lot more of the research results and information that's coming out of UCSF specifically around this.
And just one point that I'd like to add, it was something that I learned about from Dr. Kins Rhodes. Unfortunately, I don't know the specific name of the study, but she was talking about a study for prostate cancer patients. It was a clinical trial that really provided extra support to our less resource men and also I think it was Black men. And actually, the Black men who participated in the study did better than their white counterparts when they were provided with the support they needed to fully participate. So I thought that was really interesting. Again, another example of how when we reduce barriers, it can really make a difference.
Indeed. Thank you for that. Another question that came up is, do you believe the impact of the big ugly bill will exacerbate the financial burden of patients and increase social determinants of health, and will funding cuts lead to the lessening of available services?
So I'm not an expert, but yes, I think that it will have impact. National policy does have impact. Cuts to our budget does have impacts. And the reason I was trying to have a hopeful message is I think we need to focus on opportunities. So I was just at a meeting the other day where there's a hospital that hired 12 financial counselors just for their cancer center. And the way they were able to do it is they did a return on investment study and showed that actually getting patients help in terms of copay and deductibles brought more money into the hospital and covered the cost of the financial counselors. So I don't know if we could do something like that at UCSF, but I think despite budget cuts, we really have to think out of the box and innovatively and leverage technology and AI. And again, I welcome your ideas. I don't know how to solve this.
Thank you. An additional question, how is Medi-Cal currently supporting cancer patients, and what changes are anticipated in its reimbursement policies?
I do not know that much. I'm not in the billing field myself. So if there's somebody here who can answer that, I know that having social workers who are well informed about the different ways to ensure that patients who lose their insurance can sign up for Medi-Cal or can keep their private health insurance through the Medi-Cal HIP, the California Working Medi-Cal HIP program, can make a difference to UCSF's bottom line. And so I think finding ways to capture patients who might be losing their insurance and giving them the good health insurance counseling is a first step. And if there's
Thank you for
anybody
that.
from billing who can answer that question more fully, please do chime in
Or add it to the chat too. We'll
or add
also
it to the
follow
chat.
up. Yeah, we'll also follow up if there are unanswered questions, we'll be sure to find answers and send them out to all attendees as well. An additional comment or question, sorry, is what if the patient is undocumented? Can they still apply for financial assistance?
Yes, they can.
All right. Another question, how can patients outside of the UCSF umbrella benefit from this study, for example, rural areas of the catchment area or inner city residents of other counties?
Well, if they receive care at UCSF, they will benefit from all of the different programs we offer. They can participate in our many support groups. They can contact every department in the Cancer Center has a social worker. There is a main number for the social worker. They can use the cancer support services, support groups, peer support, nutrition counseling if they are receiving care with us. And many of our support groups are open to the general publics and many of our support services. However, and again, a lot of these are online, so you can participate if you are anywhere in the catchment area.
Thank you for that. Now we have quite a few questions around the navigation committee and additional resources. So the first is the navigation, is the navigation committee open to navigators of community-based organizations or just within UCSF's system of care?
I think this is a really interesting question. It would be really great to form a bridge. So this could be a project to have a bridge between the navigation committee at the Cancer Center and our partner organizations. I do think we do have some patient advisors on the committee who provide a really valuable perspective. And so I think that there are opportunities there, but as it is, the navigation committee is very large, and in order to be effective, we really need to be able to keep it to a manageable size. But I'm very open to partnering with community navigators and maybe coming to a community navigator meeting on a regular basis or find some other way to create these bridges to find out about local and regional resources.
An additional comment is one thing that was recently an issue at BOPC is a patient was coming from San Joaquin County who had Medi-Cal and they would not provide transportation because they said it was too far away. Does anyone know where we can get a gauge of mileage limitations so that we can help patient navigate?
So I think this is a really complicated issue. As I said, we do provide help with transportation. So if you have managed Medi-Cal, hopefully a social worker can help you if you're having difficulty access those managed Medi-Cal benefits. However, if you have fee-for-service Medi-Cal, those transportation benefits are not provided. So that patient might want to switch to managed Medi-Cal if it's possible. And, if they live at a great distance, it's just a matter of resource allocation. We want to be able to help as many patients as possible. And if somebody's coming from 4 hours away, paying for an Uber ride is not possible if it means that we can't serve, I don't know, a much larger number of patients who live closer by. So, it isn't a bottomless pit, this fund. This is for our neediest patients, and it doesn't mean we can serve all patients. The needs, unfortunately, outstrip available resources. And this is a challenge that we really need to think about. I wish we could meet all the need for all patients.
Thank you. An additional question, are there any efforts to change systems such as Medi-Cal to support, I believe they're referring to social determinants of health, I appreciate patients can meet their immediate needs, but what can we do to change systems that keep people in poverty? That's a tough question.
That is the $1 million question. How do we solve poverty? I think that it has to do with very broad changes that we need in society. It has to do with taxation. It has to do with priorities of where we invest our funds. And so while maybe within the hospital setting, we can't change the world to fully address these social drivers of health inequities, we can change the world for one patient at a time, and we need to figure out how to do that.
I'm not sure on the context of this question, but it looks like there was a question about having clinical trials be part of the process of some of the things you were presenting on.
Access to clinical trials.
Perhaps.
I think that, there are many efforts to include a greater number of underserved patients in clinical trials. This is a big focus of the Office of Community Engagement. And I think there's an opportunity for sure to do more collaborative work on this. But Dr. Palmer, maybe you could speak a little bit to some of the efforts that are being done at the Office of Community Engagement to improve recruitment rates for our Black and Brown patients to participate in clinical trials.
Well, I think this is, I can't exactly answer that clearly, at least not today, but there certainly are efforts across the board, particularly in the cancer realm, particularly, for example, hematology oncology or prostate cancer program also has some efforts around clinical trial enrollment, but that's kind of that's a bigger issue that perhaps we can circle back to in future CAB meetings or CAB2 ChatnChew meetings. One question I want to get to before, okay, we still have a little bit more time, so a comment made is that this all sounds amazing, but I feel like what's missing is what hasn't been mentioned is culturally relevant, responsive resources and services. How is that being woven into all of this?
Well, certainly, for example, with regard to some of the materials we develop, we have worked with our interpreter services and also several members of the CAB board to discuss how to make these materials culturally appropriate. So the patient guidebook was reviewed by several organizations and was also approved by our interpreting services. And we made some significant changes in how that was offered. I know that there are physician trainings that UCSF conducts for culturally appropriate communication and sensitivity. I think it's an ongoing challenge that we need to work on, and it's something that is an ongoing process. Is there anything more specific that you wanted to address with that question?
For the person who put in the chat, you're welcome to chime in if you wanted to clarify anything.
Thank you. Thank you so much for asking my question, and thank you for the presentation. It was very informative. And we're doing, I mean, that it just shows that we're doing great things, but there's so much more to do. And with regards to my question, the reason why I'm asking is for the population that you mentioned that was probably not part of the survey or didn't get the communications from the cancer center and with the SDOH survey and what have you.
Well, just to let you know, those survey questions do go out in different languages to patients.
Right. So my name is Lucy Latu. I am from Talama for Tongans. We serve a community-based organization in San Mateo County serving the Pacific Islander community. And what the ones that I'm guessing that you didn't get was for my community, for instance, it goes beyond just the linguistic barrier. It's the cultural, meaning having someone sit down, like the face-to-face is so much more important. Like it's culturally rooted, where having someone sit down and explain these things to me and or to my community, and being able to walk them through it, because as you mentioned, life is overwhelming to begin with, and then being inundated with like a cancer diagnosis, that's even more. And like you had identified, the needs of the patients became more after they already started treatment, but they were being asked about their needs right when they started treatment, so you don't know what you're going to get. So the culturally component part was, for me, was having like someone sit with me and go through things and walk through, because I'm also a marinator. I like to marinate with information before I can actually make a move on stuff. So that's the cultural component that I was wondering if that is being woven in, because sometimes when you're
Yeah,
dealing with
I
cancer, you just
think
want to have, someone talk to you as a human being, not as a patient.
I couldn't agree with you more. I think this is a really important issue. As I said, only 3% of patients responded to that letter. That speaks to what you're talking about. That really, when we're overwhelmed, I mean, certainly so it relates to certain cultural groups, linguistic groups, but I think to many of us who don't belong to any particular cultural linguistic group, having that person who speaks to you one-on-one, holds your hand, walks you through the steps is really important. Um, with regard to the SDOH screening, unfortunately, we don't have the staffing capability right now to have everybody with SDOH needs to be contacted one-on-one. We do capture a lot of those needs, and social workers do reach out to patients through the social distress screening, through the SDOH wheel that's visible in the medical chart. So it's not that patients don't get that one-on-one support, but it isn't consistent. And I think that we need to figure out a way to think creatively, whether maybe it's by having a lot more patient volunteers who have had cancer, who are retired, who have experience, who could be trained to maybe contact patients and then triage those needs and address some of the low-hanging fruit that doesn't need special expertise, and then send the more complex questions about health insurance, counseling, maintaining social security benefits, or things like that to social work, or patients with high distress to psycho-oncology. So we will need to think about how to do that one-on-one, face-to-face, and we haven't solved for it, but I think it's a really important point that you bring up and something we need to work on.
Thank you for responding to that. And thank you, Lucy, for chiming in. I think we have time for probably one more question, which actually seems to be a pretty big question, so we can taper it down if needed. But what strategic policy and infrastructural steps are necessary to scale this program statewide across all California counties, and what adaptations would be required to replicate its implementation effectively across diverse counties throughout the United States?
Well, I don't think that's above my pay grade. I think that what I would like to focus on is how to roll this out effectively at the Cancer Center and at UCSF so that every patient gets the support they need in accessing resources. And honestly, if we can do that effectively, I will be thrilled. And then maybe we could write a paper. But I don't have the answer of how this could be rolled out across the state. I'm sorry.
Well, I do think that, when we've been able to demonstrate success in one institution, that's when it can begin to be rolled out beyond that, showing success and what are some of the pitfalls and whatnot to address or to avoid. This is where implementation science comes in, actually implementing what's been evidence-based. So thank you for taking a stab at that. I believe someone had their hand up, but then they just disappeared. So let's see who. Was there another question, burning question before we wrap up?
Dr. Palmer, I just wanted to highlight, there's questions about, the navigation efforts that are happening between both groups. And I just
Mhm.
put in the chat that you and I and Rox are going to be meeting with Keren later this month. So just want to let everybody know, stay tuned.
Yes, I'm really
Yes.
looking forward to that meeting and
Yes.
learning more about what you are doing and trying to leverage the expertise in both groups.
Yes. Almas?
Hi, Dr. Palm and Karen, thank you so much. This is a great education and we need it in our community. I would love to invite you to our immigrant rights. I sent it to you guys if you see it. But I just want to also know, like, what is the recovery rate for cancer in UCSF? Because there's a lot of our communities, a few people that who was admitted with cancer into UCSF had lost their lives, and I wanted to see like exactly what is the recovery rate at UCSF with cancer, and then if you are willing to come to our event and then partner with us and educate our population, since there's language and system barriers, a lot of our people even they wait until the last minute until the cancer goes beyond cure. So it's good to have prevention education and also learn people can learn more about cancer issues. So thank you so much. Yeah, that's my question.
Sure. Well, I think that, what's the recovery rate for cancer is a very complicated question because it really depends on what type of cancer and what stage of diagnosis. However, I can say that UCSF is ranked first in Northern California, and I can't remember exactly its ranking nationally, but it's among the top 10 cancer centers in the country. And so we take the most complex cases, and so our recovery rates compare very favorably to other hospitals. But again, it does depend on the type of cancer. And with regard to your request to come to speak to your group, I could maybe help find somebody with more expertise in immigration rights, maybe a lawyer who deals with these issues, who would be better able to speak to the rights of undocumented workers than me. I think it's a really important topic to educate people on, but I don't feel that I have the expertise to do so. I know a little bit, but not that much.
And almost if you were referring to education around cancer awareness, you can reach out to our office and we can try to coordinate or collaborate in any future event or with your organization. You
Yeah.
can just reach out to us.
No, Gila is coming anyways. I'm not talking about immigrant lawyer. We have lawyers here.
Okay, great.
I'm not asking you about that. This
Okay.
can take care of that. I'm asking you about cancer education, and then Gilai from UCSF is also he will be here. So I don't know if you guys know each other, but Dr. Ross have referred him to come and do the training, and he's going to have an information table on
Oh, that's
Thursday.
great.
But somehow, if you guys can communicate with him and maybe help him with the materials he need, that'll be great.
Who did you mention? I missed the name.
Gilai.
Just
Oh,
maybe,
Gila. Yeah, yes.
Yeah,
Gila's a
Gilai.
part of our team. Yes.
Yeah, so he'll be here. So
Okay, great.
all right, thank you so much.
You're very welcome. Lucy?
Sorry, I know we're running out of time, but I just wanted to quickly say that the inequities and disparities that you mentioned and how the staffing is limited, but I would encourage the partnership with community-based organizations who are already working with communities that may have not been seen in your survey or being identified as needing the help, would be a help to UCSF and the cancer navigate the system, because they're already in the communities and they have access to the community that many bigger organizations don't have, and so I would encourage the collaboration with community-based organizations and going from there.
thank you. Yes, I think that's an important comment on how to build bridges effectively and collaborate.
Awesome. Thank you. Thank you, Keren, for such an informative presentation. There's lots happening, comments in the chat, appreciating your resources and sharing of the work that you're doing. We certainly appreciate you joining us today. For all of those in attendance, please be sure to complete the evaluation. Eva put the link in the chat so that we can get ideas for future topics, but also get feedback for today. And if there were questions that you didn't get answered, we will follow up if it was in the chat. Otherwise, you can also feel free to reach out to us at any time. Thank you for
Thank you so
joining us.
much.
Thank you, Keren.
Thank you.